Hello, everybody. Good afternoon. It's so great to see you here today. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute. And I would like to welcome you to the second session of our Bring It Learning Series, Health Insurance Marketplace Changes in 2026. The Bring It series is made up of 5 one-hour educational sessions about health policy topics related to issues that may be considered by the Kansas legislature this session. The sessions are an opportunity for you to bring your lunch, your questions, and perspectives to these very important topics. So, KHI, or the Kansas Health Institute, is a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation. And we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or stop by our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings like today's event. It is my pleasure to introduce my colleague, Cynthia Snyder. Cynthia is a senior analyst here at KHI, and she will be facilitating today's session. So over to you, Cynthia.
Thank you and good afternoon. First, I'm going to discuss the changes in the marketplace, and then we will be joined for a panel discussion on how those changes impact safety nets and consumers. In the chat, you'll find a resource guide PDF that contains the resources mentioned today. In the guide, you will find direct links to the recent marketplace brief. You'll be able to access the annual insurance update infographic, and you'll also be able to access the info hub to learn more about insurance in your specific area. And I'd like to also thank my colleagues for their work with changes in the marketplace. There's been a lot to keep up with, as suggested in the chat. And today we're going to talk about those changes and how those changes in the ACA marketplace impact Kansans. But before we jump into the marketplace, let's look at the big picture of insurance in Kansas to see how the marketplace fits. So if you're familiar with the annual insurance update, you'll kind of notice some similar branding here. Everyone in Kansas either has private coverage, public coverage, or they are uninsured. The majority of Kansans have private coverage, often through an employer. So private coverage includes employment-based insurance, military and TRICARE, and direct purchase. So the ACA is direct purchase private insurance. So it fits in the scheme of things in that orange box in direct purchase. Okay, so let's look more specifically at the marketplace. So what is the marketplace in Kansas? So again, it's that private direct coverage. It's available online through the federally facilitated marketplace. So individuals and families can compare plans, enroll in private health insurance coverage, and potentially qualify for income-based assistance. Now, assistance comes in the form of advanced premium tax credits that lowers the monthly premium cost, and cost sharing reduction that lowers the out-of-pocket costs of using the insurance. For many households that do not have affordable coverage through an employer or qualify for public insurance, such as Medicaid or Medicare, the marketplace is a source of coverage options. And we'll ground ourselves a little bit in the history of the marketplace, but then also introduce a new concept, effectuated enrollment. So if you look at the graph here, the yellow line represents the number of Kansans that have enrolled in the marketplace during the open enrollment period each year since the marketplace started in 2014. So that's the yellow line. But we also want to introduce the dark blue line, which represents effectuated enrollment. And we'll talk a little bit more about effectuated enrollment in the next slide. But here I wanted to contrast that effectuated enrollment is basically how many of those enrolled in Kansas paid their first month's premium. So we're able to continue their coverage. For the period of enhanced subsidies, the effectuated enrollment was close to the number of those who enrolled during the open enrollment period. For example, last year in 2025, a little over 200,000 people enrolled, and a little over 192,000 paid their first month's premium or effectuated enrollment. So you'll probably hear and been hearing and may hear more about the difference between enrollment and effectuated enrollment. So we want to spend a little time so you can see what those different numbers mean. Um, and so your effectuated enrollment is what they consider that true enrollment um, from the folks that have coverage for the first month. So when we look at effectuated enrollment again. Effectual enrollment is commonly used to describe the marketplace, those in the marketplace that paid their first month's premium. Enrollment changes every month as consumers enter and exit the marketplace. So in the individual marketplace, consumers can cancel their coverage or stop paying their premiums, but they can only enter the marketplace through the open enrollment period or through a qualifying event. And so another thing to think about in terms of the difference is the advanced premium tax credits are paid directly to the insurer, but the monthly premium balance not covered by APTC is paid by the consumer each month. So when you think about this as compared to employment-based insurance, where the premium's taken out of your paycheck every month without you making a direct payment. So that's another nuance to think about in terms of as there's more discussion about who made that first payment. Um, so we'll be watching for effectuated enrollment numbers as they become available. Okay, here's who's enrolled in the marketplace by federal poverty level. Now, we don't have the 2026 numbers. We're not likely to have those numbers until later. For Kansas, the largest number of enrollees and certainly the highest growth with the enhanced tax credits has been the consumers with income between 100 and 150% of federal poverty level. So that yellow line in Kansas. And you can see the big changes that happened with that yellow line when enhanced tax credits took effect. Um, so in 2025, and again, we won't know the 2026 numbers specifically for income levels until later, but for low income Kansans that in this range of income, um, it's their participation has grown to over 100,000 in 2025, or nearly about half of last year's marketplace. We'll know more about the income distributions of enrollees in 2026 this summer when that data is released. There also been a number of big events impacting the marketplace in the last calendar year. Here's some of them. So January of last year, the enrollment period ended with the largest enrollment so far. And by February, 96% of customers who had made their first payment, or what we just talked about in terms of the effectuated enrollment. There were three big policy events last year, and we'll talk about each of those. The first one was the Market Integrity and Affordability Final Rule, which was just issued in June. And then the One Big Beautiful Bill Act was signed, which codified many of the policies outlined in the final rule. But several of the policies, there were changes in the effective dates. And in August, some components of the final rule were stayed in litigation. And we'll talk about more about those changes in just a second. And at the end of the year, that the enhanced tax credits that were part of ARPA and continued through the IRA ended. And so that was also a big discussion point last year. Sorry. Next slide, please. The 2025 final rule, here's some components that are not in litigation. So the Marketplace Integrity and Affordability Final Rule proposed several changes to the regulation, and here are the couple that are in effect. Low-income households can no longer enroll year-round as of August. The new rule that came out last week proposed this as a permanent change instead of just through the end of 2026. The final rule also updated the definition and narrows eligibility for some immigrants and now excludes DACA recipients from the ACA. So those were big changes that weren't in litigation. Now, stayed in litigation, the next slide, is the So on August 22nd, the Federal Court of Maryland stayed several major components of the 2025 final rule, and the Fourth Circuit Court hadn't ruled before the beginning of open enrollment. So here's a couple of things that did not take effect for the 2026 open enrollment. The premium responsibility payments, which would have been a $5 monthly charge to enrollees with zero premiums who did not update eligibility during open enrollment. So we'll hear more about updating eligibility later as well too, but that was stayed in litigation. And then there was also changes in the timing of when tax credits needed to be reconciled. So that was another change that took effect. Oh, I'm sorry, that was stayed in litigation. Um, Now, impact on future enrollments. Um, so many of these have maybe have a different date. So the next fall, there'll be a shorter enrollment period for 45 days of open enrollment instead of the 75 days we've had for the last few open enrollment periods. For plan year 2028, enrollees must actively re-enroll and verify information each year to receive APTC. So again, that idea of actively re-enrolling and verifying. So stayed in litigation, but now in a slightly different form is starting in 2028. So there was a removal of the APC repayment caps. So households must repay all excess subsidies when reconciling their taxes for plan year 26. So next tax season for those enrolled now. All right. Now let's take a look at premium prices and cost to consumers. Okay, so you've probably heard a couple of numbers that in the last few months. One thing that I've heard is that premium costs have gone up 30%, and the other is that premiums have doubled. So let's look at what each of those numbers reflect. So first, for a silver benchmark plan, the price has gone up 28.9% on average. This reflects changes in the underlying premiums and doesn't capture the additional increase that consumers would pay for premiums resulting from the ending of the enhanced APTC. So again, these are the base premiums that before any APTC is applied. So if you take a look at the insert on the brief and the resource guide, you'll see that the premium prices for your area in Kansas, and you can also find out information about how much the price has changed. Now let's look at what the consumer pays. And a question about the slides. We will have a recap that'll come out after, that'll have a copy of the webinar and additional resources, and all that will be on our event web page. And so you'll have access to all of that. All right, so let's take a look at the average impact on a family of four. So this is what people are talking about when they say the premium prices have doubled. This reflects the effective change of what someone or a household at 250% of poverty will pay for their premium share without enhanced APTC for a silver benchmark black. So the original APTC still applies, but it's without the enhanced APTC. Remembering this is with and without. So we'll take a look at more closely at those numbers. Now we're looking at how the underlying premiums have changed over time, with a noticeable jump between plan years 25 and 26 for all categories. Remember, this is the full price, and most consumers get some sort of assistance. A family getting no assistance in the marketplace would pay over $2,000 a month on average. Again, this varies by your region and your state. Let's look in the differences in enhanced APTC and the original APTC. Okay, how much APTC depends on income and family size and is based on the federal poverty level. Different incomes will be impacted in different ways. Let's look at some of the examples of income levels. And I want to clarify that enhanced tax credits have ended and the original ACA tax credits are still in effect. So with enhanced tax credits, enrollees at 100 to 150% of poverty, and remember from a few slides before, that's about half of the Kansans enrolled last year, benefited from a zero or nearly zero premium plan. Now those individuals and households pay between 2.1% and 4.2% for of their income for a silver plan. So for a family of four making 100% of a federal poverty level, the premium would be $56 a month. So this is a household that's making about $32,000 a year. For a family of four making 150% of federal poverty level, or a little over $48,000 a year, the premium is $168 a month. So and at this income level, it's assumed that both kids in that family of four are enrolled in CHIP. All right, let's take a look at 250% of federal poverty level. And for different consumers, uh, all at the 250% poverty level, the out-of-pocket premium costs have about doubled. So a 27-year-old is paying about $275 a month. Um, and again, it depends on what part of the state he or she lives in. A family of four at 250% is paying $565 per month, assuming that the two kids are in CHIP. And for a couple in their 60s, they're paying $372 a month. So again, this is where I believe what they're referring to when they talk about how the premium costs have doubled. And it's certainly true across the different scenarios for this income group. All right, and next. All right, now for the folks at 400% of federal poverty level, the premium costs are about 20% higher um, than with enhanced APTC. And so for a 27-year-old making 400% of the federal poverty level, it's about $520 a month, a little over $1,000 for a family of four at this income level, and $700 per month for a couple in their 60s. Now remember that the advanced premium tax credits run from 100% to 400%. Now there's a cliff at 400%. And so anybody above that income bracket will be paying the full price. And so that would take us back to the slide where we looked at what the full price underlying premiums were in Kansas. All right, next. So we'll keep watching for changes in the insurance market. Last week, a new final rule was proposed for the marketplace, and we'll be watching for the potential impacts in Kansas. We'll also be watching for the effectuated enrollment, as well as the characteristics of enrollees that come out to better understand those enrolled in 2026. So look for the marketplace enrollment brief in August. In the brief, we will discuss how consumers enrolled, which plans they enrolled in, and their average monthly cost. So Victoria, did I miss any questions in chat?
Not as of right now, but feel free to message any questions about any data or anything that is not clear.
Absolutely. All right. Well, let's shift from looking at the changes to looking at how those changes will affect not only consumers, but also the health systems and safety net providers where Kansans seek care. It is my pleasure to introduce this afternoon's panel. We have Alice Weingarten, the Chief Strategy Officer from Community Care Network of Kansas. Also joining us from Grace Med Health Clinic are Dr. Julie Elder and Juven Nava. Dr. Elder is the CEO of Grace Med, and Juven is the Director of Community Outreach and Communication. Thank you all for joining us.
Happy to be here.
Good. So you all bring a wealth of experience with you. And so tell us more about yourselves and your role, but then also a little bit about your background and how it really makes sense that you're where you are now. We'll start with Alice.
Thanks, Cynthia. My name is Alice Weingartner. I'm the Chief Strategy Officer at the Community Care Network of Kansas, which is the state's primary care association. Prior to joining the association 6 years ago, I worked for a couple of different health centers in the state, as well as in the public health field. I had the opportunity to work with both Juven and Dr. Elder at Grace Med, and just in a variety of different roles. So it has led me to my current role as the Chief Strategy Officer, where I can work across the state with all of our members. We have 21 health centers in the state, as well as a number of community-based clinics. For those not familiar with community care, we serve more than 355,000 Kansans in this network of clinics. And that was over 1.17 million visits in 2025. And I think some of the things that are most interesting, and I think where we'll start to see changes as these health insurance changes happen, is these health centers are already serving 40% of all uninsured Kansans in the state. And along with that, 23% of those are covered by CanCare or the state's Medicaid program. 21% are in rural Kansas, and that's 12% of the total Kansas population. So that 355,000 people served is 12% of the overall population. So these health centers are already having a significant impact, and these changes will definitely have an impact on the service that they continue to deliver.
Thank you, Alice. And Dr. Elder?
Sure. Hi, I'm Dr. Julie Elder. I'm a general internist. I've been with Grace Med for about 13 years this spring. 11 years were spent as the chief medical officer, and I've been in the CEO role permanently for about a year. So community health is near and dear to my heart. I feel that it is my calling as a medical professional. And like Alice said, I mean, we see these effects every day in our patient population, and we anticipate more changes to come.
Thank you. And Juven?
Hi, everyone. My name is Juven Nava. I'm the Director of Community Outreach and Communications at Grace Med Health Clinic. I've been at Grace Med for about 15 years now. I've overseen our ACA certified application counselors at Grace Med since the beginning of the Affordable Care Act. Been able to really enjoy in working with the community and doing a lot of community outreach. And so thank you so much for having me.
Thanks for being here. And I want to point out that we've dropped into the chat from Alice a map of where the safety net clinics that are members of the Community Care Network of Kansas are located. So you can download that resource as well. And Alice, I'll start the first question off with you. So from an association perspective, what are you hearing most frequently from safety net clinics right now in terms of insurance coverage, access to care, navigation, all of the changes?
Sure. I think one of the biggest concerns that we hear about are just individuals continuing to access their care that they've been receiving. Our clinic spends so much time trying to help individuals manage their conditions that when it starts to cost them more to seek their care, continue that care, it just becomes harder for them to maintain their appointments and their relationships with their providers. And with that, we end up seeing those downstream impacts of chronic conditions getting worse, progress being lost in the healthcare that they received. I think in addition to that, that even goes in addition to with experiencing the rising costs that are taking place and the number of more uninsured that will come into the clinics, which then has an overall impact on health centers' operations, both clinically and financially.
Mm-hmm. So, Dr. Elder, what surprises you most about how insurance changes show up in your either in your clinic, or in your operations, or in your patient care?
Mm-hmm. Yeah, I think for me, it's been astounding just the increased cost of insurance. We know that healthcare is expensive. Taking care of ourselves in general, medications, appointments, whatever, can be really expensive. But boy, we hear it from patients. And, I can give an example. Recently, we heard from a mom of 2 kids, used to pay less than $200 for her premiums every month, and without subsidies, that's going to go over $1,000 a month. And then patients are forced to prioritize, like Alice was saying, they are forced to choose clothing, food, shelter over their healthcare. And so that does translate into more extreme conditions, walking through our doors, all of those things. And so we've seen those changes ebb and flow over the years in different circumstances when people lose a job, or maybe they go through a life change like a divorce and they lose benefits, or so things like that. But this is a greater volume potentially of patients that are affected, and it really does dictate how we help them in the clinic. And sometimes we have to get very creative in the ways that we can help.
Thank you. And Juven, when someone walks into GraceMed or walks into one of your community events, uh, what's the most common reason that they're seeking help?
Yeah, I think a lot of people will think that the most common reason is just for assistance with enrollment, but honestly, it's just to understand the marketplace. I think we can all agree that the marketplace can feel overwhelming. There are like plan tiers, there are deductibles, there's so many different things that people might not understand, and so they don't want to make a mistake, or it might cause an issue for their coverage. So
Mhm.
many consumers will come to us afraid or wanting to make sure they do things correctly. And so they want someone who is certified, who is trained, who's basically going to be neutral and who's going to walk them through step by step. And so for us at GraceMed, we spend about 1 to 2 hours per appointment, and that's intentional. We want to make sure that we're going through the application and really explaining things on how coverage works, what monthly premium means, things like that, so that they know how this entire process is going to work and how that coverage to care happens. And so for us, we're really looking at the families individually as a family unit to see what are some of the things that they might be concerned about. If it's either the cost, if it's not understanding, what's going to be covered. Those are the things that we're looking into and helping them.
Yeah, that's a tough job.
Yeah.
Before we get into health education, let's spend a minute back on uninsured and underinsured. So when you're looking across multiple, Alice, this is for Alice, we're looking across multiple clinics. What are the shared challenges that they're relating with regard to individuals that are uninsured or underinsured with some of the high deductibles?
I think probably one of the first challenges is just figuring out how are you going to cover those costs, because there is a cost to those individuals and still providing them services. The health centers have sliding fee scales. They have discounted medication programs. They do everything they can to try to make things as affordable as possible for the patients that seek care for them. Or from them. And so part of the challenge, I think, is helping people understand how to navigate that system,
Mhm.
what services and what resources are available. I think one of the things I found most interesting during my time in the health center is, in talking with individuals who don't have access to insurance or who are struggling with the insurances that they have, is often they say, I don't want to use resources that other people might need more. And so really trying to encourage them to use this system, because we don't want them to get to that point where their health is worse and it's more
Mhm.
expensive to seek treatment. And so I think those are some of the challenges the health centers face, and how do they engage with patients to help them understand the system is really designed to support them.
Thank you. Thank you. And I'll ask the same question to Dr. Elder from your perspective, uh, as a CEO, as a clinician. What do you see as the challenges? And you've talked a little bit about this, but what additional what are kind of so how do you approach that as a clinic?
Mhm. I think from a clinical standpoint, in times like this, when patients are struggling to afford their care, you shift more from a mindset of prevention to more of a mindset of putting out fires. And I say
Mm.
that because patients will sit on conditions and they will wait until things are very extreme or severe. They'll stretch out their meds. They might take a pill every other day instead of every day as it's prescribed. I've seen it done with insulin, patients self-dosing because they can't afford medications or insulin, that type of thing. So it really does affect the way we think in the clinic, from the clinical side of things, shifting that mindset from preventing disease to really putting out fires. And it's in so many ways, I wish all patients knew about community health centers and the ways that we can help. There are many things that we can do to help a situation or to prevent complications, before they start. Like Alice mentioned, the 340B prescriptions, just even vouchers for patient visits. I mean, we have ways to help, but that is something that from an organizational standpoint, we're constantly monitoring because we are funded, we get federal funding and state funding, but oftentimes it's based on the number of the level of poverty of our patients. And so as the number of uninsured patients goes up throughout the year, the cost of care overall increases as well. And so we as an organization keep a close eye on that too, trying to help every patient that we can get the care they need with the resources we have.
All right, thank you. And Juven, it looks like you've also got a question in the chat. So you've got a question of, do you know who in the state helps get our CHW certified with insurance eligibility? And if that's not the right question for you, we can try to find that out offline and let her know.
Yeah, by CHW, I'm assuming they're talking about community health workers.
Yes.
Okay. I'm not sure how community health workers can get certified. For us, we go through CMS. So we've had to build like a CDO agreement with CMS, and then CMS will send us a training. We have to upload like an Excel sheet with everyone who's going to be a CAC for GraceMed, and they all have to go through that training to get that certification. So I'm not
Okay.
sure how CHWs work, but that's what we do for GraceMed.
Okay. Thanks for letting us know, and we'll try to find out more offline and see what we can get that question answered. So for your second question, I'll ask, so what are common points of confusion or hesitation that you see when you encounter people exploring what their coverage options? So this is that health literacy piece. What are the kinds of questions people asking you that really they need help understanding?
Well, if there's one thing that's consistent is that people don't understand how the system actually works. People often really don't understand how subsidies are being calculated. They're unsure about like their advance premium tax credits, how their income is going to affect everything. That's usually like the where the confusion can happen when it comes to us assisting them. Cost is always the number one hesitation. Like Dr. Elder and Alice mentioned, people are thinking about the cost. Every family is evaluating how their monthly premium fits their budget. Even if subsidies lower the premium, they're still asking, like, what will this really cost me? If I go to a doctor, what am I actually paying here? A lot of times, we are having to spend time explaining coverage to care. What does it mean? What's going to be your deductible? What's going to be your monthly premium? Things like that. And so it's a lot of information overload to understand such a
Mhm.
complicated system. The other sort of confusion and hesitation that we see recently is just how much information is being just distributed out to consumers. Social
Mm.
media, news cycle, like all these policy debates, things like that can be overwhelming. And so for us as CACs, what we're trying to do is make sure that we're up to date on all the information, that we
Mhm.
have all the factual information that's up to date, that's being provided us at a federal level to help our Kansas consumers understand the ACA.
So as you were relating the things that are, that you're addressing when you're doing the navigation, it occurred to me, that's one little bucket. So the ACA is one little bucket in terms of understanding folks that have Medicare, Medicaid. Well, there's a lot of insurance systems to navigate,
Definitely. And I
and
think and I'm sorry, Cynthia, but
no,
for us,
please.
for our CACs, they're also certified eligibility workers for Medicaid. And so it's having to learn two different systems and as well as having to understand how private coverage works. And also having those resources available for those who are going to be uninsured of what's available in their communities, so they can get access to the healthcare that they need.
And it may be subject to change.
Right? Exactly.
Very true. So let's talk about that health literacy piece because I think that comes up a lot. That the challenge of navigating the system, the challenges of understanding coverage. So let's talk about, and this can just go out as a group, and feel free to uh, for anyone to jump in, and we can absolutely go around to the three of you because I think you all have unique perspectives. What are the key barriers people face when trying to obtain or maintain coverage? And what strategies have you seen that help improve understanding or health literacy? And I won't limit it just to the education piece. What strategies do you see that are working to help folks address those key barriers?
I'm happy to start. I
Okay.
think, one of the things the health centers do well, and really isn't a funded activity, is the outreach and enrollment work that they do. Those are sometimes the first individuals that a person who walks into a facility is going to connect with so that they can understand how to utilize the system. I think the addition of the community health worker role will be incredibly impactful. The more that role grows within the health center and just across the state, period. I think the other strategy that's been really helpful is the relationship building that's happening.
Mhm.
Health centers don't work in a silo. They work and connect with community partners. And the more they can educate and inform their community partners who are also sometimes working with that same population, they can help inform them and help them navigate the system as well. So I think a lot of it, about reducing barriers, it's about the relationships that are built and the information that is shared.
Yeah, I would echo that, Alice. I think it really does take a village. There's so many moving parts and so many uncertainties. And even at the level of our clinicians, they don't always understand the nuances of different programs. And so even internally having Juven and his team, but also having other folks within the organization who can navigate for patients, who can ask the right questions or say, oh, wait a minute, we're going to connect you with Juven and his team, or just being able to collaborate and ask the right questions on behalf of patients has been critical within our organization.
Thank you.
And I'm really glad that Alice and Dr. Elder mentioned that. I mean, for us, it is a lot of outreach. It's what I call the grassroots efforts. We are trying to meet consumers where they're at. So if that's at churches, libraries, community centers, building these partnerships is very important. We are trying to educate them and provide them the information. As much money as we can spend on marketing and digital and traditional media, we're really going to get a lot more benefit when it's meeting the consumers in their own backyard. And if it's even going to other FQHCs or community health centers, that's what we do. I'm very blessed that in my team, I have one team that focuses on Grace Med patients, another team that focuses on consumers outside of the community, to provide those opportunities to meet consumers where they're at.
Mhm. No, thank you. Thank you. And again, this we'll put this question out to everyone. What's that one question that you wish more people would ask, whether about coverage, access, your programs? What is the one question that you just want to be asked? And again, we can start with anybody.
I'll go ahead. I'll start this time. For us, since we're seeing consumers more one-on-one, I think this can take such a long process of filling out doing the application process. I do wish that more people would ask, like, how does this plan actually work? I think there can be sometimes this hesitation of wanting to ask because they don't want to seem as though they're not understanding it. But I think I wish that they would want to spend more time to really understand the whole coverage to care process. So what does this mean? What does it look like? Do I need to renew this? Do I come here next year again? Things like that. I wish that they would spend more time wanting to know how it works because it can be complicated. I mean, it took me
Mhm.
years before I finally understood how my own health insurance works. So I think it's really important that they would spend time with us.
Thank you.
For me, the question would be, how can a community health center help me? And because there's so many ways that we can help, there's so many opportunities for patients within a community health center. And although we're very similar in nature, we're also very different. And so services that Grace Med provides may be different from services that another community health center or FQHC might provide, and vice versa. And we really do work together. We collaborate. Oftentimes patients go to different health centers. And so I think just if folks knew the resources available within a community health center, it would be invaluable.
Thank you.
Yeah. And I would just add to that, I think going back to the beginning of the conversations, I mean, health centers really were established 50 years ago to meet the needs of those who struggle financially. And so they're set up in such a way that they are here and prepared to serve anyone, regardless of their insurance coverage, regardless of their ability to pay. And I use the term ability because there is a cost to receiving that care. And these clinics aren't free. And there is a cost sharing that needs to happen sometimes, but they work so hard to identify what are those ways they can provide that care in the most affordable way possible. And sometimes that's a relationship with a community partner who offers a scholarship or a voucher program. Sometimes that's a grant that they pursue. There's so many ways, and they're so creative in doing it that it's really important that folks utilize their health centers and utilize them well, so that the health of the overall community can be impacted positively.
Thank you. And thank you to all the folks in chat who have responded to the question that started in terms of CHW training for insurance. And so it looks like that question has been addressed. Victoria, before I ask a couple more questions, are there any questions in the chat that I missed? Oh, Victoria, I think you're on mute.
We had a question in the Q&A about ICHRA enrollee numbers. But currently KHI does not capture that information. We primarily work with employer and or direct purchase type of data. So, but it is an interesting area that we haven't ventured into yet.
And I'll just put it broadly out to the panelists. Is that any type of coverage that you have familiarity with? Okay. Okay. So we'll probably have to answer that question, see what resources we can find offline, and let you know more about that. That is not something that I necessarily follow, so I don't have a good answer for your question. All right. I'll ask about opportunities. So what do you see, and again, group question, what do you see as the opportunities for improvement right now? And again, it can be broad, but just throw that out there.
I think the more that we can convey the needs in the community health center settings and the needs of our patients to our legislators, the more weight it's going to carry. Because I do think there's strength in numbers, and the more voices that are heard, the louder we sound. And we've seen that already with different aspects of legislation that's been passed in support of community health efforts and supporting our patient populations. But I think there's always an opportunity for more and for our voices to be heard.
Thank you.
I would second that as well. And I also think that, obviously the Rural Health Transformation Program is here in our state. And so, all of these partners coming together to look at ways to improve access across the state. I think there's just so many opportunities for the state of Kansas to work together. So that there's some exciting times ahead.
For me, I think an opportunity for improvement is definitely consistency when it comes to these changes, or when it comes to policies, and also accessibility. I think it's really important to have as many people who can assist one-on-one with consumers who do have a lot of questions. If it's at community health centers, if it's other opportunities or other organizations that can have CACs. I think that would make it easier for people to understand, but also to have access to information.
Thank you.
Mhm.
And then we also had a little bit of clarification in terms of the question that was for the employer-sponsored ACA plans. And so we look at the individual ones in a lot of our products here. But Linda Shepard from our organization looks at it sort of a broader range. So I'll connect the question with Linda and have her respond to you offline. She may have more information to answer your question. All right, so let's do one last question, and then we'll turn it back over to Rebecca. So what's one thing that you want this audience to understand or remember about access to coverage and coverage and care in Kansas? So what's that one takeaway message that you want to make sure is front of mind as we end our panel today?
I would just go back and reiterate that health centers are for everyone. Regardless of what your insurance status is, they want to serve everyone. They can serve everyone. And so I would encourage you to check them out within your local communities.
Thank you.
Yeah. And when in doubt, ask. You know, a lot of this doesn't make sense or it gets confusing, but there is no shame in asking.
I would agree with Alice and Dr. Elder on everything they just said. Yes, the other thing too is that there's a human side to all of this, and to make sure that when you are providing those assistance or when you're giving, when these policies are being developed, that you think about the human nature of it, that it affects everyone, and that sometimes there are going to be a lot of questions, and so to be patient with everyone to try to explain it. Yeah.
All right, thank you. Well, thank you all for joining us today and sharing more of your perspectives through whether it's from association level or clinic level or from the individual level of a person at an event. I think it's really important to keep in mind the different perspectives, and that as policy changes are made, that it really impacts so many levels of the system. And so with that, I will turn it back over to Rebecca to walk us through the closing.
And so, once again, this resource guide is really meant to be something that you can take with you to continue exploring these resources. There's some discussion questions on there that you can take back to reflect on your own or with your teams, and some contact information if you want to follow up with some more questions or thoughts that you'd like to share. And so you can download that from the chat. This will also be available on our website in about a week, along with today's recording and PowerPoint slides. And then we'd like to also invite you to our next session. Our Bring It session next Tuesday is all about understanding OBA or HR1 and its impacts on Medicaid and CHIP in Kansas. So be sure to tune in for that session as well. And of course, feel free to hop into our website and check out all the other resources that we have, from other events to info hub dashboards with a lot of data that you can really dive into specific areas that are, represent the communities that you serve, as well as publications that have been recently released. Hey, and once again, thank you so much for joining us for our second Bring It session, and we hope to see you next Tuesday. Have a wonderful rest of your day. Thank you.